Okay, everyone. I hope you can hear me okay. It's good to be with you again. And thank you for the week off. And I hope you all had a good Father's Day weekend. So it's back to the heart of the summer. And let me see here. Okay. As always, I want to thank the Lupus Foundation of America, Georgia chapter, and Terry Iman for helping to set this up, get the word out, really provide the structure and the background resources to do this each and every week and every day throughout the rest of the year. And also to acknowledge the Georgia Council on Lupus Education and Awareness with Chris Reed and Representative Kim Schofield and the GOAL project out of Emory. So the virus marches on, and you get numb to these numbers, but they keep piling up, and you can see the US continues to lead the world, and Brazil had rocketed to second, and now it's solidly in second. And you can see that the trajectory of Brazil is just tremendous. But behind that is Russia, India, and the UK. And here you get a sense of the global hotspots. And the US is overall the same, but we'll circle back to that in a minute. It's a bit misleading. But in terms of relative increases, the global hotspots have definitely increased in total numbers since we last showed a similar map like this. And similar to a couple of weeks ago, 45% of all deaths, if you think about this, 45, nearly half of the world's deaths due to COVID are in Latin America and the Caribbean. So our neighbors to the south, for a lot of the reasons that you can imagine in terms of relatively poor resources, and a lot of lack of response from the governments themselves, have led to that disproportionate impact. Now, going back to the US, this is the number of cases over time, new confirmed cases, that is. And let's just start with other countries. You can see South Korea peaked very early and then has come down. Finland has peaked and come down. And then you can see Germany here has peaked and then has come down. Italy, and you remember the horror stories of Italy, they peaked to the level similar to the US, and they've come down. Now, if I can jump to Spain over here, they had a tremendously high peak, even much greater than the US, and they have since come down. Whereas the United States has peaked, and it's basically been peaked. And I think this was well said in another talk that I heard. There's this talk about a second peak in the US, and actually that's kind of a misnomer because the US has never stopped peaking. And so it's a continuation of what we've had for quite some time. And the fear is that it just may get even greater. So the peak will just continue to move on and be greater than it was before. So this outlines kind of what's been happening in the US generally. And as I mentioned, up at the top, you see new reported cases on a 7-day rolling average, and it's pretty much stayed the same. It's come down a bit, but then recently, as we've all heard, the new cases have gone up tremendously. Now, what has not gone up yet is, thankfully, the new reported deaths by day, and that has steadily come down. And some people think that this is an early sign of plateauing and maybe an uptick. But the way that you can put all of this together for the US in terms of increasing new cases, but not yet increasing deaths, is probably in large part due to the fact that a lot of the new cases are in the relatively young. who are not going to have as much of the severe outcomes as older individuals and with other comorbid conditions, but some of them do. And certainly young people can spread it to other people as well. So we'll have to see how things look over time. But this is a reflection of a lot of the spreading that's going on through the relatively young. And the bulk of what's been going on in terms of these cases, you can see from a map of the hotspot that I showed a couple weeks ago, as opposed to recently. And you can just get a sense there of just a growing number of hotspots throughout the US. You can see over here in California a bit, but then scattered all throughout the East, but predominantly in the Southeast. And you can see large red areas in Texas and in Florida. And here's a closer view of that. Just let you soak in kind of all the areas that are really starting to light up. And it's just tremendous, the geographic area of the total number of hotspots in Florida. So as we're all hearing, the number of cases are increasing, new cases are increasing in many more states as they were just a couple weeks ago. And this includes Georgia, but pointing out here the big spikes in California, Texas, Florida, Arizona has relatively had a huge spike. Louisiana is growing, South Carolina, relatively speaking, Mississippi. But all told, all of these states, compared to the previous rolling averages, had an increasing number of cases. And just to put some confusion to rest, you might have heard in the press about some people kind of explaining these number of increased cases due to the increase in cases in testing, sorry. And that cannot be explained completely by testing. And testing in these different states that are being hit very hard is represented by the purple here. And you can see for every state where there's an increase in tests, there is not a proportionate increase in cases. In fact, there's a lot more cases than there are increase in number of tests. So the increased number of testing to find positive cases cannot fully explain the increased number of cases in total. And to further that point, if you look at Florida, they actually had a decreased number of tests, and they had a tremendously increased number of cases, as we're all hearing, and I've been pointing out. So that's just one of a few different data points that totally disproves the case that testing explains the majority of, or increased number of testing explains the majority of the increased number of cases that we've been seeing. And it wasn't that long ago when we were talking about New York, New Jersey, and Connecticut being the epicenter of corona in the US. And here, those states are now have falling rates. And their number of new cases every week has been relatively low. And it's been so low that not only are they opening up more, but they're actually concerned about people coming from other places, especially in the Southeast. So they're requiring travelers from certain states, especially from around our area here in the Southeast, to be quarantined for 2 weeks if they come up to their area. And so how quickly things change, and that really is the nature of the beast that we're going to have to be dealing with for some time. And what a lot of people have been preaching about is that you just can't be complacent. And even though human nature will kind of point us in that direction, we have to fight that, because this is going to be a constant ebb and flow and putting out fires here and there. And unfortunately, the fire has come a little closer to home for us. Now, speaking about Texas and how hard they're being hit, it's really a dire story there. And one can say, all right, fine, the younger people are getting a lot more. They're not being as conscientious, but they're not being as harmed as much. They're healthier. And so what necessarily is the harm in that? And that may not necessarily be the case, but when you have it go throughout the population, and even if it's disproportionately in the young, there's going to be no question that eventually the overall numbers of sick people in the young, as well as those leaking into the older populations and those with comorbid conditions, is going to increase. And so the ICUs in Houston are getting overwhelmed. And they reported that they had hit 100% capacity for the first time during the pandemic, and on pace to exceed their unsustainable surge capacity by July 6th. And the reporting of accurate numbers is becoming an issue there, which reminds us that COVID continues to be part of political games in many areas of the country. And it's so bad there that I heard from a colleague that pediatric hospitals are admitting adults now in the Houston area because due to lack of beds in the adult hospitals. So we always have to be on guard. Now, one way to fight all of this, in addition to increased testing, is that once you find people who are positive, you try to mitigate the spread by informing people who have been in contact with those positive individuals, or what we call contact tracing. And when you measure that in certain ways, at least in this particular method that they used here, Georgia comes in near the bottom in terms of how well we contact trace. And so therefore, what's the point of having a positive test if you're not going to be able to do anything with that? And to help other people to test themselves and to isolate themselves and to stop the spread. But this contact tracing is tough. It's going to be a tough sell, especially in certain communities. And New York City has really learned that. They've learned that when you go into communities that have large numbers of minorities, there is a certain level of distrust in terms of public health communities and the research community in general. And then you have the government on top of that with everything else that's going on. And you have a governmental entity contact you, asking you who you've been with and their location and where have you been the last several days. It's really not going to go off well. And especially if you go into also other areas that have undocumented individuals and so forth. So, other countries can set up very good programs, and they've done it much better. And that's because they have also different environments to do that. So we face certainly some unique challenges. But there are many things that we can do. And one thing that has been definitively shown that makes an impact is wearing a protective gear. That is the face mask. And so this is just some references from different studies, but bottom line is that yeah, there's different degrees when you go from N95 to surgical masks, and then you just go from a bandana, but they all have a positive effect. And if you have a cloth mask, as most of us will have, and you go into a typical public situation, then it has a good effect. And universally, it decreases infections by around 10% on average. Some areas more, some less, and it depends on how well you use it, how often you use it. And even if you take 10% as the number, 10% is a huge impact, because each person can then infect several other people who then infect several other people, and it really gets magnified over time. So every percentage, every person that you stop from infecting another individual makes a huge difference on the public health. And this is a graphic that's been going around. I couldn't find the exact source, but if we take it at face value, it gives you a sense of countries and parts of the world and their use of regular use of face masks in public, with the darker areas being higher percentages of people. And you can see all throughout Asia and most of Africa, and you're talking Europe and South America and Mexico, and some of these areas are doing better, some of these areas are doing worse, but they're all universally at least trying to maintain their better situation or get a handle on their worse situation as a general public by wearing masks frequently. Whereas the United States, you can see, really sticks out as one area, large area. We lead the world in cases, yet we have relatively few people wearing masks in general. And if you dig down just to the United States, there's variation in terms of the regions. And you can see out west in California and Nevada, and even in Texas, it's a moderate use, and Florida, a moderate use of masking. And then in the Northeast, they have a highest use in general of masking. And they were the epicenter before, and they've learned from what could happen. And here they're able to maintain things. And then here, the Southeast, where most of the major hotspots are, we have relatively fewer people using masks regularly. And if you take at least this model out of the Institute of Health Medical they use one model where predicting on the top here the deaths, and this is true numbers in the past, how the deaths went up, and they've kind of plateaued, and they seem to be going up a little bit. And if we do not continue to use masking, then the projection is that the deaths would go up a bit, plateau, and keep going up, certainly not down. But whereas if you use significant amount of universal masking in the public, it would predict a relatively significant drop in the number of deaths. And then when you talk about daily infections, you see the same thing, whereas it would be pretty stable without any changes from what we're doing now, and perhaps even increasing down the road. You see a dramatic drop with universal masking. But it's not going to change anytime soon in Georgia. And Governor Kemp said just a day or two ago that he will not make wearing masks mandatory in Georgia. There are some areas that did reopen relatively soon, and because things have changed for the worse and the healthcare centers are being overrun, they have changed their minds and have made wearing masks mandatory. But Georgia is not going to be one of them. So speaking of Georgia, it's pretty much similar to what we saw with the overall US, in that we've had a pretty large increase. We've had stable and rates, certainly not going up dramatically, maybe slight trend downward, but that's all lost recently, and that the number of new cases has gone up a lot. Deaths have gone up and down quite a bit. And just recently, it seems to have gone down, but there are some early signals that is starting to change. If you look at Georgia and the areas that have hotspots, the whole metropolitan area is on the upward trend. But you see, again, throughout the rural parts of Georgia, especially in the southern part of the state, as well as new areas in the northeast part of the state, there are new areas that are starting to pop up. So in terms of the metropolitan area, Gwinnett leads in terms of number of cases, but you have very significant numbers in Fulton and DeKalb and Cobb. And if you look at the rates per 100,000, in fact, the highest rates are in Cobb and Fulton. It's just that Gwinnett is the largest county here. And yes, we have the overall number of cases, the highest number of cases overall, but per capita, we're talking Hall, Fulton, Cobb. And you see Doherty is just totally off the charts. going back to the metropolitan area, these are all the hospitals from the different health systems. And in the past, you see at the top here, the total number of COVID positive patients admitted to the hospital. The bottom is our COVID positive patients in the ICUs. And they both sort of trend similar lines up until recently. The number of total positive cases are going up. And you see the ICU cases are still relatively low. We're not to the point of Houston yet, but you kind of get a sense that they may be increasing. In the hospitals where I work at, there are definitely increasing numbers, not to the point where they're overwhelming the system, but it makes you worried about the trend. Got a set of questions that I'll try to address the best that I can here. How many lupus patients have contacted COVID-19? How many lupus patients have passed away from COVID-19? And if any, what have been some of the ongoing or possibly long-term effects of the disease on lupus patients? And I'll tell you right now that we don't have solid lupus-specific numbers because, thankfully, in a way, we don't have huge numbers of lupus patients alone. So the data really that we're able to have enough cases to make some general statements about are best when you lump together lupus with other rheumatologic conditions that require chronic immunosuppression. So there are some similarities with lupus, obviously, for that reason, but there are some potential differences. So you have to take it with a little grain of salt. And here, there's a study that it was looking at the fact that was just talking about that a lot of the conditions that we treat in rheumatology are chronic immune or autoimmune conditions where we're giving medications to suppress the immune system for the benefit of the rheumatologic condition, but that increases one's risk of infections, and so that makes people particularly concerned about what COVID, an infection, a viral infection, would do, and potentially would they be at high risk for some of the complications. And then you add to all of this that there are a lot of comorbidities or other associated conditions that are known in the general population to increase the risk of complications that are more frequent or relatively more frequent in the rheumatologic conditions, including kidney disease, high blood pressure, cardiovascular disease. So this group had done a study in the Boston area, including the Harvard system or Partners Healthcare, and they had 52 patients with rheumatologic conditions, 10 of whom had lupus, and there were 19 people with rheumatoid arthritis, 7 with a condition called polymyalgia rheumatica, 7 with spondyloarthritis, 3 with myositis, 3 with vasculitis, and 1 with sarcoidosis. And they were all positive for COVID. And then what they did was they matched each one of those participants with another individual with COVID that did not have any of those rheumatologic conditions, but were very similar in terms of age, sex, and the date in which they developed COVID. And then they compared the two groups, the group with the rheumatologic conditions and the one without rheumatologic conditions, all with COVID. And they looked at similarities and differences in terms of demographics, clinical features, and outcomes. And the main outcomes that they were interested in were hospitalizations and intensive care admissions, being on a ventilator, and those who passed away. And the researchers found that 75% of those with rheumatologic conditions were receiving an immunosuppressive medication. Both groups, those with and without rheumatic diseases, had similar symptoms and laboratory findings. And additionally, a similar proportion of patients with and without rheumatologic disease were hospitalized, and 44% compared to 40%. And mortality actually was similar between the two groups, with 6% passing away in those with rheumatologic conditions and 4% among those without. However, actually that's pretty much the good news. And there's a lot more good news than bad. That again, there wasn't a huge increase in proportion of people that were hospitalized with rheumatologic conditions or who were had to be hospitalized, but 48% of the people with rheumatic diseases required intensive care admission and mechanical ventilation compared to 18% of those with COVID-19 only. So their conclusion was that patients with rheumatologic diseases who had COVID-19 had similar odds of being hospitalized as patients without rheumatologic diseases. However, those with rheumatic diseases, when sick and hospitalized, seem to have higher odds of needing mechanical ventilation, which is obviously a bit worrisome. Now, I do have to end this with some more positivity, though. And here, this group of investigators took advantage of the COVID-19 Global Rheumatology Alliance Registry that I've mentioned in previous town halls. And it's a worldwide registry of cases that are reported both by physicians and by patients themselves of, again, not just lupus, but rheumatic diseases. And it was established in March of this year, and it contains information on more than 1,400 cases reported by nearly 300 organizations and more than 300 clinicians or investigators. And they focused on a month period from March 24 through April 20th, where they looked at 600 cases of COVID-19 among people with rheumatic diseases across 40 countries. And they found that about 46% of these patients were hospitalized. And that actually means that more than half, a little more than half, recovered without hospitalization, and 9% died. Somewhat similar numbers with the other studies. We're talking about anywhere from 6 to 9% mortality rate, which is not too dissimilar to what's in the general public. And when they looked at the analyses as to what factors may be increased with greater, what factors are associated with an increased risk of hospitalization, they found that prednisone dose of greater than 10 milligrams was something that was statistically significant, meaning that people on 10 milligrams or more of prednisone were at higher risk of being hospitalized. Now, before, again, I think I mentioned a study similar to this before. For those of you on 10 milligrams or more of prednisone, don't go stopping that medication. Another interpretation of this could be that those with more severe conditions requiring higher doses of prednisone, and it's because of that underlying issue, perhaps, that you're talking about a greater risk of being hospitalized. So not necessarily the prednisone itself, but that's a marker of how severe your condition is. When they looked at other medications like methotrexate, azathioprine, Cellcept, those medications were not associated with any increased risk of hospitalization. There's a group of medications in rheumatoid arthritis called JAK inhibitors that were not associated. NSAIDs, or non-steroidal anti-inflammatories, the ibuprofens, the naproxens, the Motrin, Aleve, they were not associated with any increased risk of hospitalization. There's a group of medications that are more commonly used in rheumatoid arthritis called anti-TNF biologic therapy. And examples of this include Enbrel and Humira and others. Those are actually associated with a decreased risk of hospitalization. We don't fully understand all of that yet. And again, this is just one study. It's intriguing. It's not definitive by any means, but it is building up more and more numbers of cases. And so I'm just reporting what they're finding so far. And if you're curious, antimalarials or hydroxychloroquine had no impact on increase or decrease in hospitalizations. Another thing that's been in the news recently is dexamethasone, which basically is prednisone in a different form. And that's been shown to actually save lives in people with COVID infection. So you may be a little confused. I just talked about how prednisone increased the risk of hospitalizations. Now, this is people on prednisone prior to and going into developing a COVID infection. So this is background prednisone here that's increased with hospitalizations. And dexamethasone, this was shown as being effective in people without rheumatic diseases that were hospitalized in very severe condition with COVID. And they were just about to the point of going into a very critical situation with ventilators and other life support. And dexamethasone was shown to be very effective in improving the outcomes and saving lives there. And that makes sense to me, because what is really dangerous to people is the infection itself, but it's the immune system's reaction to the infection. And for some reason that we don't understand fully yet, some people who get the COVID infection have an abnormal, very active immune response to it. And that causes a lot of trouble in terms of breathing and other issues. And so this is the story that a lot of us can relate to in terms of lupus. And many of you have been on prednisone or steroids when things have been extremely severe. And so you know how potent it can be and how quickly it can reduce the immune response. And so it's good that it's been shown that it helps, at least in a certain window when people are really sick, here, in this case with COVID. Sticking with some of the news in terms of medications, the story with hydroxychloroquine in terms of treating people with COVID continues to sort of wane, if you will. There's been more information pretty much stating that there doesn't seem to be any harm necessarily, unless you give it at a really high dose or with azithromycin, like some of the very early studies we're doing that caused some heart arrhythmias and death. But as we all know, hydroxychloroquine, when given in a more standardized fashion in the doses, is generally safe, very safe. But unfortunately, there doesn't seem to be any signals across a few of the early studies that reported results of any benefit in terms of treating COVID. And that's led to actually some studies being halted early because of that. Hydroxychloroquine continues to still be in the news a bit. And I don't know how much you all have heard of this, but I just want to throw it out for people to keep an eye out for. The US had banned the import of hydroxychloroquine from some factories in India. I didn't know this before, actually. I knew that there were some plants in India that were producing a fair proportion of hydroxychloroquine in the world. But back in March, the FDA, the Food and Drug Administration, lifted restrictions on IPCA Laboratories, which is based in Mumbai, India. And they were previously not allowed to import or export hydroxychloroquine and a similar drug, the cousin chloroquine, to the US, because they failed inspections by the US. They discovered multiple violations of manufacturing standards, and they manipulated data regarding quality checks. So the US initially barred them, but because of the initial enthusiasm for hydroxychloroquine and the Trump administration in terms of trying to stockpile a lot, the US government lifted restrictions. Now, for some reason that I haven't quite figured out yet, this past week, the FDA reversed its waiver, or it no longer allowed this company to export chloroquine to the US, but it's still allowing them to bring in hydroxychloroquine into the US. I have no idea what proportion of the market in the US has hydroxychloroquine from this company, IPCA. I have no idea if there's been any reports of bad reactions as a result of that. This is, and I don't mean to scare you, but I think we all just need to be the soldiers on the front line. I mean, who else is going to be? So if you hear any stories or of this drug being out, or people having some issues with them, please let us know. We need to keep an eye out for that. Speaking of hydroxychloroquine in general, though, since Trump began pushing the drugs as a potential treatment for COVID, as you all have heard and we've discussed before, manufacturers have donated millions of pills to the national stockpile and reserved for hospitalized patients with COVID. And from what I've read, there's about 63 million tablets of Plaquenil in this stockpile. Now, before COVID last year, 5.9 million prescriptions were filled for hydroxychloroquine. We're talking 63 million tablets. So that's probably like a good part of the year in terms of the overall US prescriptions that are filled, and total number of tablets that are given out, at least maybe several months or so. So, I mean, it's a big deal. The US is sitting on a mountain of Plaquenil. It's not going to change access for years and years, but there's enough to really impact the flow and provide it for certain places. What's going to happen to that, how that's going to go back into the market, I have no idea. I know that one company, I think it's Novartis, was discussing how, I mean, they donated a ton, but if they were going to take some back, they were not going to commercialize it or make a profit for it or sell it. But does that mean that they will distribute it, and to whom? The Lupus Foundation of America National has been working with a nonprofit hospital somewhere, and this hasn't been finalized from my understanding, to be a potential recipient for some of the stockpiled medication. So keep your eyes and ears open as to what the government's going to do with that. So even if it doesn't pan out to be anything for COVID, we certainly know that it has long-term benefit in our communities, and we would love to get access to that. So that is it for my week. I want to thank everybody for joining me again and for sending your questions. Please continue to go to the website for the Georgia chapter, lupusga.org. Go to the COVID resources, continue to work with them and other groups, but especially Terry there. She's doing a wonderful job. Keep sending questions. And I'm not really sure in terms of overall numbers, they're going down. We may talk a little bit on the side as to how we're going to keep doing these in the future. But we're always here for you, regardless if the town hall is here or not. And just know that this is just a more obvious example of how the LFA and others are fighting for you each and every day. But please keep this email in mind and send any questions or suggestions for the future. And please be safe out there, and remember to wear your masks. Have a great week, guys.